All right, class. Today we're going to cover Chapter 14, Cerebral Palsy, CP, Traumatic Brain Injury, TBI, and Stroke. So, getting started with CP, or Cerebral Palsy, if we break that word down, cerebral meaning brain, palsy meaning a loss of motor function, is a quick and easy way to define what CP is. It is a group of permanently disabling conditions, so those that are born with CP are going to have a permanent disability. There are ways to make it more manageable and to allow the individual to be more functioning and more independent through exercises and stretches and really just gaining strength and mobility throughout different activities. But it is a damage to the motor control areas of the brain, motor cortex. Symptoms vary from very, very mild to where it may only impact speech with a slight speech impairment to pretty severe where they have a total inability to control their body. Some other symptoms that are associated with CP are speech and language, the ability to motor plan, to speak clearly, and to be able to produce speech sounds, intellectual impairments, and also sensory impairments, meaning a potential vision impairment or hard of hearing or deafness. And it is one of the most common motor disorders or disabilities in children. So I had the chance to coach these three guys in quad rugby, all of which have CP, different kind of varying degrees. Each of them is ambulatory. They are able to walk. Some use a walker, some use Lofstrand crutches, which is forearm crutches, but many of them for long distances do much better in a wheelchair. And so this center guy, this is his quad rugby chair, but his wheelchair is behind, which is the blue one. But during school, he uses a walker to get around. So there's three different ways to classify CP. One is a topographic way, which is anatomical based upon the body parts that are impacted due to CP. The second way is functional, talking about the degree of impairedness within the body. And then the third way is neuromotor. So we're going to go through all three of these different classification systems of CP. So topographical, we can look at the areas or regions of the body that are impacted. So monoplegia is one body part. Diplegia is usually the lower limbs are impacted with a minor impact on upper. Hemiplegia is one complete side, whether it be the left side or the right side. So both the arm and leg of the left side and both the arm and leg of the right side, either or, is impacted. Paraplegia is the impact of the lower limbs. Triplegia is any three limbs, which is typically pretty rare, but that usually would be two legs and one arm. And then quadriplegia, meaning total body impairment, so all four limbs and potentially the neck and the trunk. So here's kind of a visual for you, some kind of pictures to tell you. So quadriplegia, all three areas or all four areas are impacted. Hemiplegia, half the body. Diplegia, usually the lower body is most impacted. Again, another way here to look at it. So monoplegia, we can see just one limb is impacted, and with CP, that usually is just an arm. Triplegia, usually both arms and one leg for CP. And pentaplegia, which you don't really hear too often, is all four legs, the head and the neck, but people usually just call that quadriplegia. So when it comes to the functional classification, this is really just looking at the range of motion, strength, and control that an individual has of their body. So class 1 is being the most severe functional classification of CP, meaning that most of these individuals are in a power or motorized wheelchair. They have poor range of motion, strength, and limited trunk control. Then we go to class 2. Usually uses a wheelchair, but has poor trunk, poor leg control, or poor trunk, poor strength. May use their legs to actually propel their wheelchair, sometimes their arms. Class 3, fair to normal in one extremity, so they probably can propel their wheelchair independently, and they may be able to walk short distances with the assistance of a walker or crutches. Moving on to class 4, they have pretty good strength, limited control issues within their arm and torso. They'll use an assistant device for distance and usually will still play adaptive sports in a wheelchair. Then we have class 5A, class 5B. Class 5, both of these have pretty good functional strength. Class 5A has good balance when they use assisted devices, and both of these do not use wheelchairs. Class 5B does not use any assistant devices. Then we can go to class 6, which has fluctuating muscle tones, walks without any aids or supports. Function may vary, so they may have good days and bad days. And they have better mechanics running than they do walking. So walking, usually we'll see some sort of a scissor gait where their legs may cross over as they're walking, or at times they may drag one of their legs. Moving on, class 7, good function, ability, kind of overall, walks and runs without aids, but has some asymmetrical action. So usually that's more hemiplegia on the affected side. And then class 8, really good balance, minimum coordination issues, kind of can run, jump freely. Some maybe slight loss of coordination in one leg, sometimes maybe one arm, and not too much of visibility of the disability. When we get into the neuromotor classification of CP, this is really just how the neurons are impacted from this disability and what it is causing as far as the impact on motor coordination. So spasticity, or what people may call spastic CP, is a very high increase muscle tone, so hypertonic. Usually have awkward reflexes. So reflexes we would typically see individuals grow out of may still arise and may still be present. Usually they have stiffness in one part of a body. They have what's called a contracture, which is pretty permanently tightened muscles and joints. So they might have their elbow flexed with their wrist flexed and kind of their fingers extended close to their chest, may be a contracture you may see. Many individuals with spastic CP or spasticity will have some sort of an abnormal gait due to the spasticity, the increased muscle tone, and tightened kind of joints and ligaments within their legs as well. Athetosis is really just uncoordination of movements. Some involuntary movements may occur as well. Then we have ataxia, which is hypotonicity, so really low muscle tone. They usually have balance issues, maybe seen as clumsy or awkward as far as their movement, maybe bumping into things as they move. And then also a mixed and combined, so having one or having more than one of the following neuromotor classifications is seen often. So what are some education consideration when it comes to cerebral palsy? One is that we want to manage and, if possible, increase their motor function. So we can do this by improving and developing muscle control. For those that have hypotonicity, those with hypertonicity, we may want to emphasize muscle relaxation, increasing range of motion, increasing flexibility, and really the main goal is to just increase their functional skills. So it may be grasping and releasing, being able to push their wheelchair, standing and walking for longer distances, being able to do some kicking, catching, throwing. Also, they may have some abnormal reflexes, so sometimes these may interfere with their functional skills. So if they are in a wheelchair, we may look at different strapping techniques with a physical therapist where we may be able to prevent kind of a reflex from occurring and just give them more strength and mobility with like a knee strap that goes around in their wheelchair, just to be able to provide them more stability as they're working their upper body. So different ways to kind of give them more function. Also, for individuals with cerebral palsy, we definitely want to collaborate and work with the physical therapist and the occupational therapist to look at different types of braces that might be used. Make sure we're inspecting those braces for any rubbing or kind of red heat spots. Where we can also look at how to use gait trainers, how best to use walkers or crutches to facilitate movement within the physical education environment. And another concern is really just to look at developing the total person. So using collaboration and team approach to not only work on psychomotor skills, but also affective, social, emotional skills as well. So I'd like you to take this time, pause the video, and I want you to write down some concepts that you learned. Write down what CP stands for, what are the different types, how is CP classified, and what are some concerns and implementations when it comes to PE, recreation, and fitness. Okay, next we're getting started with is TBI, which stands for traumatic brain injury. What TBI is damage to the brain, which can impact both physically, cognitively, socially, emotionally, behavior, function, really depending on what part of the brain is impacted. Many times this will be referred to as a silent epidemic due to the fact that a brain injury may occur where from the outside physically you are not able to see that impact and that injury. And it might not be till you start realizing the symptoms that are occurring that impact to the brain may have actually occurred. So what are some physical limitations or impairments that may be associated with TBI? Those could be lack of coordination, difficulty in actually planning or sequencing movements. So, the brain may be firing and saying, yes, I want to move my arm, I want to move my leg, and the body's just going to be delayed in the actual production of movement. There may be the muscle spasticity, which we saw in individuals with CP or cerebral palsy. There may be headaches. Speech disorders are very common. Paralysis may occur as well with different parts of the body, and sensory impairments, typically vision impairments, may occur as well. So a very vast degree of impact when it comes to TBI on the impact of the individual. So we really need to make sure that we're looking at individualizing their programs, movement programs, and looking at that one specific individual and how TBI has kind of impacted them and how to progress and move forward from that. So some cognitive impairments may result from TBI. Probably one of the most common that you'll see is short and long-term memory loss or deficits within maintaining those memories. They may have a poor concentration, altered kind of perception, may get agitated very easily. Many times you'll see some impact on their ability to communicate, whether it be speaking, reading, or writing. And at times they may make poor judgments and make kind of rash decisions and just not really using their full brain to make decisions because of the injury that has occurred. Also, within kind of that cognition, we already covered some physical or psychomotor impairments that may occur. The other areas that's really big and isn't really covered so much is the social, emotional, and behavior impact that TBI can cause an individual to exhibit. These can be mood swings, a lack of motivation to work, to sustain physical activity, to put themselves out there. They might have low self esteem, depression, inability to self monitor their decisions and their reactions. They may show excessive laughing or crying. They may have dysfunction within sex. They might have difficulty with kind of that impulse control, sort of not really thinking before reacting. They may react in what we would consider inappropriate ways based upon the situation. And they may feel a little distance and have a feeling of inability to kind of relate to others. So, brain injury statistics, it is one of the leading killers and causes of disability in children and young adults within the US. About 5.3 million Americans have sustained TBI. Males are more likely than females to sustain a traumatic brain injury. Approximately 75% are mild, with the remaining 25 being more severe. It can be caused by anoxia, which is lack of oxygen to tissues within the body and the brain, cardiac arrest, near drowning, child abuse, shaken baby syndrome is probably not the number one causing TBI, and also sport and recreation accidents impacts to the brain can occur, such as concussions is a form of TBI, traumatic brain injury. So when we talk about the classification of TBI and the degree, there's two main classifications of TBI. It is whether it's an open head injury, which is the fact that the head is still open. The injury is an open wound. So it might be a gunshot wound, could be a blow to a head, showing visible. It might be something that's protruding out of the head. So we're able to see open head injuries. The other flip side of the classification is a closed head injury. So this you are not able to see from the naked eye physically. This would be seen more so through CAT scans or MRIs. So this could be caused by severe shaking, lack of oxygen, cranial hemorrhage, or a blow to a head such as boxing. We're seeing more closed head injuries occurring in football from head to head contact in different sports. And again, a concussion would be a closed head injury. As far as the degree of TBI, it can range from very mild to severe. And those that are in this severe degree of injury usually are characterized by prolonged state of unconsciousness, and many functional limitations may remain even after rehabilitation occurs. So there is the Rancho Los Amigos scale for TBI. Level 1, the most severe, is non-responsive, so coma the individual is in. Level 2 can be inconsistent and non-specific response to stimuli, so not in a coma, but not 100% responsive. Level 3, they may be able to follow some very simple commands, very inconsistent and delayed, kind of a vague awareness of who they are, may be like communicating in kind of pointing, maybe some writing. Level 4, decreased ability to really process information, have a poor discrimination of information that they're attending to. Number 5, they're able to consistently respond to simple commands. However, they are very distractible within environmental stimuli, and usually they need frequent redirection to get them back on task and stay attentive and focused. Level 6, responses may be incorrect, more so because of lack of memory, but their responses are usually more appropriate to the situation that they're in. And they exhibit some retention of their ability to relearn tasks, such as feeding themselves, walking. Level 7, usually they have appropriate and oriented behavior. They may lack some insight or that more abstract thinking. They may still show poor judgment and problem solving skills, and they usually require minimal supervision. And last one is level 8. They usually are able, after rehab, to integrate back some gain some memory and some past events, and usually new activities that are learned require no additional supervision. So when it comes to instructing students and individuals with TBI, what are some strategies? We're really looking at the top-down approach, so very functional, getting them back to the skills that they want and need most first, instead of really the developmental, just looking at what's most important. They're going to need frequent reminders or prompting to stay on task and to be attentive. You may have to spend additional time reviewing the steps and processes to complete a task or activity. We should be making sure that we present information in simple steps, and it might be best to write them down so that an individual could go back and relook at those steps. It's also best to help them kind of organize information, and we could provide different techniques to help them remember material, whether it be graphic organizers, color code, but just to try to enhance the brain's ability to pull back that memory. We should be using a task analysis, so breaking down the skills and the movements into components. It's very important to use cooperative learning activities to make sure that they feel part of the team and part of the class. And again, color coding, providing kind of color signals within the class can also help as well. So again, go ahead and pause this video. Check your understanding on TBI. What does it stand for? What are some different types or degrees of classification? And what are some concerns and implementation when it comes to PE, recreation, and or fitness? All right, the last and final disability that we're getting into is called stroke, which probably many of you have had some experience or some prior knowledge about. So stroke is damage to the brain due to faulty circulation of blood. It can impact motor ability, motor control, sensation and perception, communication, emotions, and consciousness. And again, varying degrees of the disability, from stroke, from a very minimum loss to total dependency. Most common causes of stroke is partial or total paralysis on one side of the body, based upon what part of the brain was impacted. It is one of the most common forms of adult disability impacting Americans today, and it's usually pretty rarely seen in infants, children, and adolescents. So what are some risk factors? So increasing your risk of a stroke to occur. We have a lot of control over our ability of whether or not a stroke may happen to us or to our parents or to our grandparents. There are some risk factors that we don't have control of, which would be more so our family history, our genetics, and our ethnicity. We can't really control that, but there are many things that we can control. So things that we can control is inactivity is an increased risk factor. Drinking and drug substance abuse is an increased factor. Obesity or unhealthy eating is an increased risk factor. Smoking, again, increased risk factor. Some things that we may not be able to necessarily control would be the age, hypertension or high blood pressure. Again, if that's hereditary, if it's associated to our poor eating and exercising habits, then we may have control on that. Heart disease, diabetes, um, previous strokes and TIAs could also impact it as well. So, what are some symptoms of a stroke? This is really important just to be aware in case you ever run into a situation that you're not sure if someone may be having a stroke or not. Because it's very important that if someone is, that we call 911 and we get appropriate care to them as quick as possible. So I've always learned it as the acronym FAST. So look at their face. The one side of the face seem to droop. Are they able to smile and have their face looking asymmetrical or symmetrical? Face also, what about their speech? Is their speech different than typical as far as slurring the words or kind of dragging their words on? A stands for arms, so they might have weakness, numbness, some pain in one arm. You can ask them to raise both arms, and if you see one arm kind of drifting downward, that may be a symptom. S for speech, I usually think about speech with the F for face, so I'm sorry I did cover it some. But is their speech slurred? You can ask them to repeat a simple sentence, and are they able to repeat it in time and repeat it correctly? And T, the last one, is time. If they show really any of these symptoms, it's best to call 911 or get them to the hospital. Again, it's not our judgment. We do not know whether or not they are having a stroke, and so the best thing is that if we think that they may, is to call and get help or get them to the hospital. Some other symptoms may be cognition. They may not be thinking accurately, or they might have perceptual deficits on what they're perceiving is occurring. We might see some motor impairments. They may end up having a seizure because of a stroke, and they may show some communication problems. As far as classification, when it comes to stroke, there's cerebral hemorrhage, which is a ruptured artery. So that's occurring with bleeding. And then there's ischemia, which is the lack of the appropriate amount of blood being supplied to the brain. There's TIAs, which is a transient ischemic attack. Transient meaning usually temporary. It shouldn't really last any longer than 24 hours. It can go unnoticed. Ischemic meaning that lack of blood supply being kind of withheld from the brain, and the attack is the impact that it's causing. It does say that it may occur days, weeks, or months. That's usually multiple attacks occurring, not one attack withstanding throughout that duration. So someone might be having a TIA one day, they might not have it the next day, then another day, and these small kind of attacks may be happening, which, if not taken care of, may potentially lead to a major stroke occurring and happening. So, what are some educational considerations? Again, we usually will not see children having strokes, but for sure, if you're working with the adult population, whether at a fitness center or whether doing some recreation, there's a chance that that may occur. So know the warning signs, be aware of them. We talked about the weakness or numbness of the face or arm or leg. Many males will get it kind of near their heart, usually their left arm weakness. Some reason females tend to get right arm kind of weakness, pins and needles, sharp pain. They might have some blurry or dimness, loss of vision, impact their speech. They may have a headache really bad for no reason. They might feel dizzy. Any of these could be a sign of a TIA or potentially a stroke is occurring. And us as coaches, teachers, fitness specialists, we should make sure we know the medical history of students and individuals we work with. And seek medical attention when we think it's needed. If we think they may be having a TIA or a stroke, we should just get them help and get medical attention right away. Other safety considerations, we should monitor their activities. If they are having TIAs, we should be aware of that. If a student is seizure prone, we should make sure that we know how to properly take care of someone who is having a seizure. So definitely not sticking anything in their mouth. That is one of the biggest myths when it comes to a seizure. One thing that you could do is, if there's a jacket or a blanket or a towel, just kind of place it underneath their head to kind of give them a little bit of cushion. The best thing is to time their seizure. If they are having a seizure, at that point, you're going to call 911 and, just let their body do what it's doing and really just start counting, keep a watch going, keep yourself calm and other people calm. They may bite their tongue and blood may come out. That happens. They might urinate during a seizure. If they do come out of a seizure, just be very emotionally supportive because they might not know exactly what occurred at that point. They may feel embarrassed. So really just kind of talk to them slowly and be very empathetic with them. If they're lacking judgment, be aware of safety considerations with that. Special equipment may be used, such as bolsters, crutches, different standing platforms, or orthotics. This is more so for individuals after they've had a stroke and have had some paralysis or muscle weakness. They may be using different pieces of equipment to help support their body. Some individuals may have protective headgear on. And it's important that, students that have severe impairments due to stroke and have difficulty moving voluntarily, that we should also provide them passive movement. We can provide them physical support during activities. We can potentially get them in different posture positions, not just standing. They could be on a mat, laying down, and just really helping them execute different skills is really important. So go ahead and take your stroke notes. What are the different types? What are the causes? What are some risk factors that may increase a chance of getting stroke? And what are some concerns and implementations when it comes to physical education, recreation, and fitness? Go ahead and pause your video and write those down. All right, and that brings us to the end of Chapter 14, covering cerebral palsy, CP, traumatic brain injury, TBI, and stroke. Thank you very much. You guys have a wonderful day.